Hi, I'm Abbas Lohawala. I used to work in the service. I used to be a trainee in this service here and work for the independent organization called the Cayman Group. We have a neuro rehabilitation ward. My question is the ROC criteria. Do they apply to rehabilitation services, and do they apply to the neuropsychiatric or neurobehavioral services at all? Or is there any other criteria for neurobehavioral services?
The UK Rehabilitation Outcomes Collaborative is predominantly for units who wish to be classified according to the specialist rehabilitation unit descriptions. They don't specify that it has to be NHS provision only. They do apply to anybody who's delivering coordinated multidisciplinary rehabilitation. They are for units that are led by a consultant appropriately trained in rehabilitation medicine or in neuropsychiatry with appropriate rehabilitation backgrounds. So any units providing that sort of holistic multidisciplinary specialist rehabilitation can submit data to UK ROC. Whether that's worth their while or not is a different question, because obviously the reason it's hugely worth our while is it's going to inform the tariff by which we are remunerated for our service provision. So for NHS provision, it's absolutely vital that we sign up fully to UK ROC. I am aware of some independent sector providers who find it very useful to submit to UK ROC, both in terms of recognition as a unit for commissioners and for other people, and in terms of looking at their own complexities and analysing themselves against NHS providers. So I know that some units do it. To answer the second part of your question, I'm not aware of any equivalent measures that are quite as comprehensive for specialist rehabilitation, but I would state that UK ROC data collection does not specifically apply to acquired brain injury. It applies to specialist rehabilitation, so it includes a much wider variety of conditions than acquired brain injury. So there may be, colleagues may be able to advise, there may be measures within neuropsychiatry and neurobehavioural rehabilitation that are more pertinent. But the UK ROC is certainly the nationally accepted one for all specialist rehabilitation.
It's a good thing that the commissioning is centralized now. We have been arguing for this for many years. We had meetings with the Department of Health and so on and so forth. The bad news is perhaps that although the money has come for this particular specialist group, but the number of services or the number of specialty services that need to be included in that group has gone up since the money has come. So it's going to be distributed among more and more specialist services. In terms of UK ROC collecting data on neurobehavioral symptoms, we have had some discussion about this about 6 months ago in Southwark Cathedral in London. The nearest thing they have is FIM-FAM. And there's nothing beyond that. And we had a lot of discussion about how to include some specific measures, outcome measures, because the tariff will be attached to that at the end of the day. And some suggestions were thrown. That was 6 months ago. We haven't had much movement from there, but at the moment, FIM-FAM is the only one we have.
But just to add to that, if I may, Professor Deb, I mean, FIM-FAM is part of the mandated UK ROC data collection. We have to send that. But also the Rehabilitation Complexity Score does include weighting for patients with significant behavioural problem. So in terms of, risk, there is a score for risk, and there is a score for therapy intensity, and there's a score for number of therapists. When we talk about therapists in UK ROC terms, we don't mean just physiotherapy, speech and language therapy. Psychological input, psychologies are considered in the broader remit of therapy. So it allows you to it's really the number of disciplines involved with that person and the intensity with which they require that discipline. But the risk score does include the provision for sort of mental health support and the intensity of that.
Have dominated NHS in provision of brain injury rehab services.
Could you speak up a bit, Kieran?
Sorry, I was just reflecting that there's probably no other area in clinical medicine where the private sector dominates over the NHS in provision of brain injury services. Why do you think that's happened?
Can I give a brief comment? Yes. I mean, it may differ from my colleagues, but I get asked this question a great deal, and we have to be very open to discussing this. At one level, I think one of the answers is, certainly when we access non-NHS provision of brain injury rehabilitation, We do so because it's simply not possible to provide the complexity of input that's required for an individual within the NHS. And I think that mainly reflects the fact that we can't flex our staffing up and down appropriately. So for somebody who requires really prolonged one-to-one behavioural interventions and who requires highly specialist therapeutic input, we can't staff our NHS units to accommodate the odd patient that might have those needs. So it feels to me as though, you know, that flexibility is just precluded from standard NHS services. So I think we have to accept that there is always going to be a place for those specialist units with the ability to flex their staffing. The other thing that plays into it is that occasionally, or quite frequently, people who've had a brain injury are in receipt of a medical legal settlement as a result of their brain injury, which comes with funding for life to provide specialist rehabilitation. And you'll hear a bit more about that in some of the talks this afternoon. But I think when there's that package of funding, that opens the way to bespoke, tailored acquired brain injury services outside of the NHS. But I'm very, very interested to hear others' comments on that. They're just two initial thoughts, really.
I will give you my own personal experience, Kieran, over the years. When I used to work in Birmingham, from the very beginning, about 12 years ago, we started having lots of meetings with commissioners and local provider trusts and so on and so forth to try to develop a service. Nothing has happened. Birmingham has got a neuro rehab unit, but no neuropsychiatry inpatient beds, where Stokes has done much better than Birmingham. But I worked in Wales many years ago, and we developed a neuropsychiatric service there because the political environment was very different then. There's pressure from the Welsh Select Committee on the local health authorities to develop something because there's one of the local MPs had a relative who had a brain injury, and there's a political pressure, and things moved very fast. So unless there's a political pressure or some maybe financial incentive, it's not going to happen. But I think I'm hopeful now that, first of all, the commissioning is going to be centralized, which would help to set up more NHS-based services for people with brain injuries. And the second thing is, we grumble a lot about this opening up the back door in the NHS to allow private sector to come in or go into competition. But that competition might do some good to the NHS now, that they see themselves in competition with the private sector. And as you said, private sectors have opened up their doors right, left, and center with lots of brain injury inpatient-based services. It's interesting, it's inpatient-based services where the money is attached, not community-based services, which is lacking. That might give some incentive to the NHS trusts to develop their own service.
Can I add on to that? I think one of the factors about lack of development of these services in NHS has been the dualism of the acute commissioning versus mental health commissioning. And some of these services, neuropsychiatric services, fall right in the middle. And either side was able to wriggle out over the years, saying, well, look, actually, mental health commissioners would say, well, it's brain injury, isn't it? And brain injury, acute side, neurosciences commissioners would say, well, hang on, these are mental health problems. And none of those people took responsibility. And development of private services indicate that there is a need. Coming back to the issue about flexibility in staff input, well, mental health services are used to that. They almost any inpatient neuropsychiatry service or any inpatient mental health service would be used to dealing with flexibility of 1-to-1, 2-to-1 nursing versus 15 minutes observations versus no observation at all. So the level of flexibility of staff input is always there in any mental health service. And I think central to lack of development of neuropsychiatry inpatient services has been the dualism of commissioning, and hopefully with national commissioning and one person being responsible for doing this may help, but we remain optimistic.
I think this dualism issue is quite important. In a way, we are probably heading towards the right direction because with the central commissioning, the commissioning is with the neuroscience, and this is what we always supported from our Royal College of Psychiatrists. Although providing is still from the psychiatric trusts, but the commissioning is with the neuroscience. And unless that is there, which was missing for a long time, unless the demand is there, and neuroscience people, GPs are saying we need the service, of course, from the demand is coming from the patients and families. There isn't any pressure on anybody to develop the service.
Hello, my name is John Holloway. I'm a bit of a rare beast in that I'm an NHS consultant and yet I'm working within a private framework. My unit, which is at Frenchay Hospital, is an inpatient specialist unit. I'm a neuropsychiatrist. It is run by the Huntercombe Group, but I still work for the NHS Trust. Taking up your point, Shimi, my slight concerns about, and it carries on to the ROC data as well, is that my concern is where the investment is going to come from, because we are part of ROC collection, which I think is actually quite arduous, and certainly for a smaller unit, it's without any academic support, it's complicated. We're now going to be, we have been informed that, as you say, there's going to be a moving tariff, and as part of the gap in our services, we've got very little place to move people onto. As a result, though, we're a level 1 service, and I'm sorry if this starts getting a bit technical, so we're on a good rate of pay at the moment to provide a specialist service. If we get stuck looking after long-term patients and getting small amounts of money in as a result as their payments drop, we will no longer be able to set up or maintain our specialist service, and there's a risk that we become more generic. And I think similarly, I think for anyone who wants to move upscale and start looking after these patients, I think there's a risk unless investment comes from somewhere outside. I'm not sure how we will develop specialist services in the future, because I can't see where the money's going to come from. I think funding will get reduced and there will be a lack of specialism for our patients.
I don't know if this answers your question, but I think there is a real need to look at how the next step of rehabilitation for those people is funded. And certainly there are rumours that there is going to be a similar data collection drive funding stream approach, data collection driven funding approach to community-based specialist rehabilitation services. So it doesn't stop at the end of the level 1, level 2 episode, but actually the patient moves into the next episode of community provision, and there is some way of quantifying the funding for that pathway, but that's very unclear at the moment. I know that some units are looking at models of having step-down rehabilitation beds or step-down rehabilitation services in their areas to ensure the throughput. And I know that there's a lot of work going on via the clinical reference group for complex specialist rehabilitation at the moment, looking at what happens beyond the typical 6-month stay. So when the patients have their 6-month stay and the funding drops off, as you say, how you either apply for continuation of funding if they continue to need that very intensive specialist input, or how you identify the next stage in the pathway. But I think you're right, there will be a bottleneck and we will need more and more specialist rehabilitation beds. One of the things we're doing in the West Midlands is looking at that capacity issue, and particularly alongside the trauma work, we would expect an increase in capacity because more patients are going to be surviving from major trauma, and it's those patients who survive are going to be occupying the specialist rehabilitation beds by default. So we know that there's going to be a capacity issue, and we're trying to quantify that at the moment. I'm happy to share that work with you if that's of any interest or any use, but I think there is this still unanswered question of the pathway beyond inpatient specialist care to be addressed.
Exactly, I agree. I think what you have heard about Neuropsychiatry Service Commission, that the inpatient neuropsychiatric service is going to sit with the clinical reference group, which is going to be centrally commissioned. But beyond that, the outpatients and community-based services, there's a bit of a question mark. It is, I believe it is temporarily within the CRI, but it could go to CCGs. And then I don't know whether the local GPs would ever agree or prioritize any funding for this group. So we have to watch this space. If it goes within the central funding, this bit about rehabilitation, that will be really, really good. And it might, as you said, it's early days yet. So I'm hopeful that at least you've got a foot in there in the central commissioning. Another problem, of course, you face, I mean, I don't look after inpatient beds anymore, but I remember from the days when I used to do that, this bed blocking. So moving patients from, I think it probably happens in the private sector as well. And if you can't move patients, if you don't have that turnover, then you don't get the referrals, and it sets up a vicious cycle. So that whole pathway needs to be looked at and properly funded, unless it won't work. So you're going into the social services and social care as well. Did you want to say anything, Neeraj, before?
No,
Okay.
that's fine.
There are two hands, so we'll go to the gentleman first, yes.
Hi, I'm Gavin Newby. I'm consultant neuropsychologist for the Cheshire Brain Injury Service. And I have the fortune or misfortune to work right across quite a lot of the journey of suffered by people with a brain injury, both at the post-acute neuro end, but also people out in the community. And it's a very long journey. And the truth is that we need input and resources right across the journey. And it was great to hear regarding the rehab trauma network that you are looking at early input into rehab trauma, input early into people's journeys. But what I think there's a real danger of, although it's a bit more encouraging what you're saying, is that there's a danger of things fizzling out, because commissioners will see that, well, we've perhaps invested in beds, we've perhaps invested in bricks and mortar. What more do you want? They don't necessarily see the whole journey. And some of the comments earlier about some of the neuropsychiatric problems, for example, will come out 10 years post-injury. In fact, I've just picked up somebody who was injured in 1972 and has a whole stack of difficulties. So that's one part that I just wondered what your views are and how to keep the momentum going and make sure that with all the financial issues faced by the whole economy, that there isn't just a fizzle out. And the second thing is just really very practically, just picking up the point you were making, Neeraj, about neuropsychiatry almost existing in isolation. And as a neuropsychologist, yes, we are often banded together in things like Headway leaflets. Just very practically, in my trust induction, I happened to see somebody who was a consultant on learning disabilities who has a background in neuropsychiatry. I wondered if he might be interested in doing a pilot clinic. Yes, he was. I happen to also know the consultant in medical neurorehabilitation. Would you be interested in coming to this clinic? And we've managed to do a 6-month trial, which has actually now been permanently funded. And okay, it's a drop in the ocean. It's 1 day a month, but actually, just in terms of formulating people's difficulties, getting people access to the right psychiatric knowledge, medical knowledge. I mean, even just very practically trying to get adults onto Ritalin, for example, has been a huge issue in terms of getting prescription protocols and things like that. But I suppose I'm saying that if you're prepared to be flexible, it is possible.
I mean, we did propose this spoken hub model because we have to be practical what is achievable. It's a huge demand there, and in practice, it's not possible to meet all the demands in the foreseeable future. So in terms of the neuropsychiatric MDT is concerned, that includes neuropsychology and nursing and etc., one possibility is the spoken hub model, where you have center of excellence maybe in the big regions working along the trauma centers, but then in all the other districts, you have psychiatrists specializing, maybe spending 1 day or a session. One example is adult ADHD service. And this is an area where the demand is growing fast. Doctors and general public are getting more aware of the symptom and the diagnosis, yet the service isn't there. And even among the psychiatrists, the expertise isn't there. So I know there's one example in Leicester where somebody developed the service, and then he asked his general adult psychiatrist colleagues to come and sit in his clinic to kind of train those people. So they go away and run their special interest sessions. And if there's a complicated case, they will ask for advice from the expert in the center. So that's possibly a model which will work in practice and is doable and financially viable, rather than having specialists in every district, which won't happen, definitely.
No, I agree. I think it's very heartening to know, how people have gone about, against the tide to develop these clinics and services which don't exist. But I think it's important that they are linked up, they are integrated, because what some of the audits have shown that people could be unhappy about, A, they may not know that these exist, or there might be a while before people can get into these clinics. So I think there has to be a system where, hub and spoke model or some kind of integration where they're linked up with acute services and then post-acute, whenever these needs arise, even if 10 years down the line, they can be straight away sent to a specialist clinic rather than having to go through generic community mental health teams. I think there was another question somewhere.
Yeah, we'll probably take the last question before lunch. Was there another hand raised somewhere behind you?
For me, the big issue is money. Where is it going to come from? I think we need to, just following up what this gentleman said, we need to work creatively, inventively, and utilize what experience we have available. I mean, at the end of the day, once you've sold the family silver, you can't buy it back.
Mm.
I think you're quite right. Money is the biggest issue, and particularly in terms of setting up the longer-term community services. Once the acute side of things has fizzled out, as Dr. Newby quite rightly says, there is a risk. How do we get those specialist community services funded? And in anything within rehabilitation, from my point of view, you have to try and quantify the socio-economic costs of not doing anything for these people against the cost of providing a service. And that's where I think more joining of health and social care trusts together, such as my own partnership trust, finally we are getting through to them the message that actually if you assist people 10 years after a brain injury to get back into employment, to stop breakdowns of relationship, to stop even potentially criminal behaviour, the reduced burden of care for those people is economically viable and can fund the pathway. But it does require a leap of faith from commissioners, and when money is tight, that's incredibly difficult to obtain. And particularly when clinical commissioning groups are predominantly comprised of clinicians who see a very small number of patients with acquired brain injury in their typical working day, it's really difficult to put the focus on them. And that's why we absolutely grab things like the major trauma spotlight while it's on us, and we try and shoehorn it into community rehabilitation service, because it's in there. You've just got to be crafty in how you make it count. And that's why we've all used the long-term neurological conditions NSF, again, to try and shoehorn what we require in terms of community pathways. And you just have to keep banging the same drum and not get disillusioned. But it's difficult.
This argument worked very well for IAP services. They managed to argue with the government that by not treating vast majority of patients in the primary care for anxiety and depressive symptoms, country is losing billions of pounds from economic loss and employment loss and so on and so forth. The same argument could be made about brain injury patients, but the case hasn't been made as strongly as the way IAP service was developed. But maybe the way forward is the peripatetic type service. The otherwise is very difficult. Before we end, we have a chief executive here. I mean, this issue about where the money is going to come from, and you're not the commissioner, I know, but your headache is to develop a service. You have to think about where the money is going to come from, and you know all the tricks in the.
Thank you for putting me on the spot. I've just been sitting here reflecting. I worked for a long time over in Canada, and one of the things, we all know that the resources are challenged, and I think we're all very cognizant of that. But one of the things that we did over there was very much as a prime contracting model, where providers would subcontract with other providers, not necessarily the statutory ones, but also other voluntary sectors, for the continuum of care down a pathway. And I've just been reflecting, we've got, I don't know if there's any commissioners in the room, but there's a lot of expertise here, and it's about being very clear on the outcomes that we want to deliver for patients, and also where we need to put the specialist input and how we could perhaps influence commissioners to think differently about allowing us as providers with all the expertise around to subcontract different components of that pathway, and allowing other voluntary sector people working with us very closely to actually facilitate that enhanced care to patients.
Definitely. Is there any commissioner here on the you don't want to put her on the spot. She's hiding wherever. Okay, on that happy note, we are going to break for lunch. There's